So I thought what I would do is put together my 11 top tips to help you in managing different injuries and different personalities in sports that you will have to design a prescriptive rehabilitation program for. So my first tip is, as a practitioner, be you a doctor or a physio or a trainer, you need to know the sport. So you need to read about it, you need to watch it, and better still, you need to get involved. And that's important because you want to develop a trust and a rapport with the athlete. And if they know that you've taken an interest in the sport, so if you know some of the key players, you know what some of the points tables are standing at for that season, those players will gravitate towards you. And if you, for example, play hockey or participate or watch hockey in some way, those hockey players will be more inclined to consult with you as a practitioner because they feel that you'll have some empathy and understanding the intricacies of that specific sport. So my second tip is to get to understand the athlete in front of you. So when you start your assessment and meet this athlete, you've got to develop a relationship, but you also want to know what is their level of competition. So are they school level, are they national, are they international? And if they're in a team event, what position do they play? If you don't understand the sport, then get an understanding from that patient in front of you to get an idea what they do in that team, to try and get an idea if it's more of a strength position, if it's requires more agility or more speed. And you also want to know, are they coming to you before the season starts, so pre-season, or is this in the middle of competition time or in season, or has the season finished, so they're in a post-season period? And that's important because it gives you an indication of what type of rehab the player or the athlete will be more likely to be able to do, because often they have large competition demands. And what are the aspirations? Sometimes we get kids that come in and all they really want to do is not be left behind when they have to do run around the school field. And that's as important an aspiration as somebody who wants to get a gold medal at the Olympics or wants to make the national team. And what other sort of psychosocial factors do they have? So, athletes often have, many emotional components that sometimes are even more challenging than the average population. They've got things, fears, denial. Often they'll initially deny that the injury is going to slow them down or is going to affect their performance on the field or track or wherever they are. They might have various mood disturbances, and you need to be cognizant of those. And what sort of injuries? Remember that injuries do threaten athletes' careers, and certain injuries in professional athletes could have a large financial implication for them, and that can be quite scary. And often, in fact, I had an athlete or a cricketer today who said that when he had to stop his sport, he felt like he went through a divorce. The emotional trauma for him was enormous and something that he continues to struggle with. And so we have to be cognizant of these type of issues. Also, is there financial support? So who's paying for the session that they are coming to see you for? If the athlete or the player is paying themselves, then often there's a lot more compliancy and buy-in. Whereas if your fee is being covered by a national body, sometimes the compliancy is less. So certainly something to ask or to understand. And do they have good emotional support from family, friends, and spouses? Again, gives you an idea of the sort of security or stability they've got at home, which will certainly impact on your management. So my third tip is that for you to conduct a thorough and detailed subjective assessment. So some people call it a subjective assessment, you might call it the interview, but you basically are interviewing that athlete to try and develop an understanding of what their problem is, be it pain, stiffness, or instability, for example. And so your assessment has to be detailed and it has to be relevant to the problem and relevant to the person sitting in front of you. So you need to visualize the problem that they're presenting with as well as its significance to that person. So I could obviously run a course for a day on subjective evaluation, but just a couple of tips. First of all, take an accurate history. It has to be carefully annotated and detailed. And I always say that if in your subjective examination you can't find it, then you can't treat it. So by the end of the assessment, you have got to be able to understand exactly what the problem is. Some of the important questions, of course, are, is it a traumatic injury or a slow build-up with a history of overload? So either an acute injury or a gradual onset. And again, that will give you quite a lot of information. What is the exact mechanism of injury? So you want to know, how exactly did it happen? So if they say they fell on an outstretched arm, try get them to demonstrate that to you so you can have a better understanding of which structures are implicated in that overload. You also need to understand, is this an acute injury? Is it a subacute injury? Is it chronic? Is it persistent? Is it recurrent? So to try and get an idea, and a recurrent injury implies to you that something is ongoing and perhaps there's a biomechanical issue that hasn't been identified correctly as yet. Also, we'll ask things such as pain at rest, pain at night, to give us some more red flag information as well, amongst other things. So pain distribution, you want to know the intensity, the pattern, and the behavior of the pain. I'll ask the patient to be very careful to demonstrate to me the exact distribution of the pain, as well as any referral patterns, so that I can have a better understanding of the possible source. The patient might not complain of pain, they might be complaining of instability or locking. We also need to be cognizant of any sort of yellow flags or psychosocial issues, self-esteem, anxiety, anger, frustration, what are their coping strategies? Do they have any avoidance behaviors? So they try and avoid things that they think are going to hurt them. And what are their pain beliefs? You know, do they believe that pain always means harm? Are they terrified and want to avoid pain at all costs? Do they think that pain means that they have some sort of extremely serious pathology? So we need to have an understanding of their cognizance of these issues. Part of the special questions I like to ask are certainly on the medications. Now, certain antibiotics, such as quinolones, have been well identified now that in an active, very active population, as one subgroup, they can basically shut down the tendon. So use of quinolone antibiotics, such as Ciprobay, for example, which is used for upper respiratory tract infections or for any sort of gastric irritation, diarrhea, those type of antibiotics can actually shut down the tendon, and you may find that a tendon rupture is associated with a use of quinolone antibiotics, the half-life of which is 6 months to a year. So you have to go back in the history and see if you can identify a commonality between those two. Does the patient take antidepressants? And that's important because that will give you an indication possibly of some sort of psychosocial issues that they are struggling with. Crestor for high cholesterol is known to create stiffness. Reacutan, which is used for acne, can cause severe muscle spasm. So these are the type of things that you need to ask, which will really help you in your prescriptive rehabilitation program. Have they had any x-rays, ultrasounds, MRIs, or MR arthrograms? And those, obviously, you need the reports. Other things that might make a difference on your rehabilitation strategies are, what comorbidities does the patient have? So diabetes, COPD, seronegative spondyloarthropathies or autoimmune conditions will have a large impact. Maybe a relationship with poor core control, for example, related to continence or irritable bowel. And what is their sleep hygiene? So whether you have COVID or you have a tendinopathy, sleep is very restorative, and it's an excellent antioxidant and is very important for healing of all structures. So if somebody isn't sleeping, that's also, again, a flag that it could slow down your management and be a detriment to your rehabilitation. So I'm very emphatic about getting all the reports, getting op notes, getting reports from trainers, physicians, if there's an isokinetic test. that's been done. I need a report, and I take all those reports and file them so that I have a very detailed history of that specific individual. So I often say it's a bit like playing a game of chess. You can't play the game if the chess pieces aren't on the right positions on the board. So if you don't start with the bishop in the right place and the rook in the correct place on the chessboard, you can't play the game. And same here with when we're looking at a subjective examination. By the end of that examination, I need to be able to visualize the problem. I need to try and have identified the mixture of associated factors for this particular person. And we're never going to get all the information at one assessment, and sometimes people forget to tell you stuff. So I always end up with a sentence, is there anything else you'd like to tell me? And then I can sort of say, oh, I forgot to tell you, somebody suspected I had ankylosing spondylitis, or I forgot to mention I had surgery on my knee. And that's also a little bit of a get out of jail card for you, so that it opens the door so that you're not going to miss any important information. So when you ask the athlete to demonstrate his functioning limiting activity, it's really hard in a clinical rooms situation. So if Nadal comes to you for treatment and says, when I hit a topspin forehand, I get pain at the back of my shoulder, no matter what you do to test him in the rooms, you're never going to replicate the force and the speed that he would do on the court. So that always remember that the most functional activity is the activity itself. Everything else is a simulation of that activity. So we're trying to simulate the functional activity, but it's often not that easy to do.